Welcome back to another riveting show of It's Your Health, your leader in healthcare news. Remember to check with your doctors before we do anything. I'm here with my brother, Dr. Dan Benyo, and I'm Phil Benyo. We'll be back in just a minute with some brief headlines. Welcome back to It's Your Health. We're ready to shoot off the first segment and start talking about riveting headlines. I found these rather interesting. I didn't prepare any of these headlines, by the way. These are all prepared by my brother here.
Always. Yes.
And so I found these to be very interesting. I might have to challenge you on some of them. So first headline, the early bird loses weight. They actually did studies that showed it matters what time you work out.
Yeah, it's very interesting, and early bird gets the worm, right? And so those who work out early in the morning versus those who worked out later in the day actually lost more weight when they worked out earlier. Actually about 5% more compared to those who worked out later in the day.
That's wild. We have people that come to our gym, some are there at 4:30, 5:30 in the morning, some are there at 6 at night. That's going to change the dynamic of things. All right, next headline, let's move on. Bypass bone loss. After now decades of having people have certain types of gastric bypass surgery, we can see some issues with bone loss and osteoporosis early.
Sure, and it's usually the Roux-en-Y type of gastric bypass that usually has the most success in weight loss, but it is one of the more aggressive forms of it. They showed to stave off the weight loss, the best way is to exercise. And so people who exercised after they had their bariatric surgery in an appropriate time frame actually were able to keep their bone health and not kind of dip into that osteoporosis range.
It makes sense. The older surgery that we really don't use very much anymore had a lot of issues with malabsorption as well. And so the newer surgery is designed to combat that. Last headline in this segment, no shot rescue. The FDA recently approved an intranasal glucagon.
Sure, so people who have diabetes, who are mostly on insulin, who end up having low blood sugars, hypoglycemic events, that's actually could be more worrisome and dangerous because it can lead to death. They'll become unresponsive. You check their sugar, it's in the 30s. And so one way people will take diabetic candy, which has glucose or dextrose in it. Some people will be unresponsive because of the blood sugar being so low. So instead of administering an injection, now they have a nasal spray, which can help build up the amount of glucose in their body. And then they should seek probably some evaluation by the healthcare either emergency department or call their primary care physician.
Yeah, usually people have a pretty good plan of action, but you're right. What happens when you can't eat or drink? It's harder to get that sugar up, and so an intranasal option certainly is good to have. Well, let's move on now, and winter is fast approaching. We're not technically in winter, but there's snow on the ground. It's 18 degrees this morning. Let's talk about some of the different health things that we have to think about in this winter. Do I have to sit and worry about, going and getting a cold if I go outside and it's too cold out? What kind of ramifications can happen with this cold air and these icy conditions?
Sure, winter is coming, so to speak. So a lot of times what we see is chronic conditions during weather changes, and that spans across many different kind of spectrums. And so people who are breathing in cold air, sometimes we see a worsening of COPD, sometimes asthma causes more irritation of the airways that can cause a lot of problems. They start using their inhalers, nebulizers, having more symptoms. And so that puts them at risk for kind of decompensation or getting worse with their chronic condition. So a very common one is to put like a scarf over your mouth when you're breathing, so it's humidified air, so it's not as cold, it's not as kind of sharp on the lungs. Additionally, if it's icy out and you have gait issues or walking issues, is to be careful that you don't slip and fall. I mean, that's a game changer. We've all seen it. People out there walking, they're trying to shovel their driveway and they slip and fall. Additionally, people with high blood pressure or heart disease that go out and start shoveling a bunch of snow because 3 feet dropped out back, they start getting kind of a stress test for their heart and they fail it. So those are things that we have to watch out for. Additionally, the food around the time of year also. People with heart failure and salt ingestion, people with diabetes and cookies. And so it's around the holidays we have to watch what we eat sometimes.
Yeah, one of my favorite sayings is we call them holidays. It's not a hol week or a hol month. I have people that'll be, the end of January, and they'll be telling them, like, well, why is your sugar still up? Well, we still have a lot of cookies left over, and Christmas season. I'm like, you're not Orthodox, you're not celebrating some Christmas I don't celebrate, or Thanksgiving, but it's the middle of December and they're still eating all kinds of crap from Thanksgiving, and that, that's really unacceptable. That's what's going to get you in trouble. You have one bad day, that's not going to get you in too much trouble. You start stringing them together and start stringing them in the weeks, bad things happen, and you're going to set yourself way behind and get yourself really sick. And so it's important to keep them as a day,
sure,
not a week, month, or a year.
Yeah, and it's moderation. I mean, as you said, it shouldn't be a week or what have you. And certainly you can string in a few days with weekends and what have you. But when you start seeing people coming in and their legs are kind of the size of tree trunks because they haven't been watching what they're eating, or they've had a lapse in taking their medications, you start seeing kind of those side effects that in some patients require hospitalization, especially during a time of year that people want to be at home and not in the hospital.
Yeah, it's that's self-induced. That's something that can be prevented. So, moving on, I know there's we're talking about bypass in our headlines and the different types of surgeries, but they're starting to change when we use this. You used to think of using gastric bypass or the different procedures for a younger person, but now they're starting to show that that's not necessarily true. We can use it in older populations.
Certainly, we're starting to see, at least from the Europe side, they usually start things initially a little bit first before us, that people after the age of 65 have done well with kind of bariatric surgery. And that's not something I've thought about kind of in some cases. There are patients who do fit the bill who could get that. Unfortunately, as you get older, those chronic conditions start to kind of pile on, and so you may not be the best surgical candidate to kind of get a bypass surgery. Traditionally, we like bypass surgery when your BMI is above a certain range, when you have chronic conditions that are due to the weight, like diabetes, sleep apnea, arthritis. And so you're young, you're relatively healthy at this time, you get that surgery, those conditions reverse.
Right. Well, I think that just about wraps up the first segment. I think we're going to have to take a little break for some brief commercial messages, and we'll be back for the second segment of It's Your Health, your leader in healthcare information. Welcome back to the second segment of It's Your Health, your leader in healthcare information. We're going to get back to some headlines. Testosterone for postmenopausal low libido. A recent study published in The Lancet showed that they're starting to show some usage for testosterone replacement for females with libido issues.
Very interesting. We don't really look at testosterone supplementation in postmenopausal women, so this was something of interest that I saw. It does come with its own risks, of course. We've talked about this before in prior shows about testosterone replacement having some significant adverse effects. One is it increases your LDL, so that increases kind of stroke and heart attack risk. Increases in women acne and hair, which may be unwanted side effects. In men, of course, it has a whole host of side effects, but overall it can increase libido if that's something that is significant enough to require testosterone supplement. Certainly you'd want to talk about it with your provider.
It's certainly a big risk versus benefit talk. There's a lot of risks, and you have to gauge to what degree that benefit is important. So moving on. A recent study in the journal of Stroke talked about marijuana increasing the risk of stroke. I didn't know marijuana caused anything bad.
Oh, well, you haven't been watching it, your health, because we have talked about it in the past, of course. It's thought that usually it's the inhalation of marijuana. Now, let's say, first and foremost, medical marijuana we've talked about, it does have its specific uses. It has its certain place in medical care. This is more of people who are using vaping devices as well as inhaling smoke form of marijuana, that from the age of 18 to 45, they saw an increased stroke risk in younger individuals who not necessarily would have that risk. And with the more usage of that, their risk even went up higher. So it's certainly something you have to be aware of.
Yeah, I sometimes will have patients say that. They'll say, well, I don't smoke. And I'll actually push for them. You mean you don't smoke anything? Well, I only smoke marijuana, but that's fine. I don't smoke cigarettes. I'm like, well, it's a yes or no question. From a risk standpoint, it really doesn't matter what you smoke. The fact that you're putting a burned product into your lungs just has badness written all over it, and you're kidding yourself to think that that's a healthy alternative. And let's move to another headline, kind of in the same vein. A Michigan boy, 17-year-old, gets double lung transplant. The first time this has ever been done due to damage from vaping.
Yeah, it's unfortunate. We're seeing these reports almost weekly now with vaping-related lung injury. They even have an acronym for it. And so it's unfortunate, and lung transplant is not a small task to undergo, and then it's not one and done. They usually don't do too well in the coming years as well. And it's from a vaping device. And they're finding that maybe it's from these homegrown vaping solutions, which aren't necessarily regulated. But I would say just vaping in general, it's one of those things that I would avoid if possible.
Yeah, this is, they just had this on the news. They're starting to think there's links to some of the other things that are put in the vape if I told you, vitamin E is supposed to be healthy for you, well, they're sticking that in the vapes, and that might be the culprit. They don't know. But that could be one of many culprits, and this is an industry that we're going to look back in 10 years and be shocked that we ever even considered doing this.
Oh, yeah.
I don't think you're going to see it in a few years. All right, let's move on to some more topical things to review.
Very good. You're like our dad.
So, someone has to sit and fill that role. But let's look at some of these pictures. Here's someone who has, they come in, here's their neck. They have these kind of rough, scaly patches. They sometimes bleed. They're not getting bigger, but they're not getting smaller. They tried putting some cortisone cream on. It kind of takes the redness out, kind of doesn't. What do you think?
Well, given that they're kind of older, they're itchy, they're kind of indolent, it's something that we kind of commonly see. We see them on the face and sun-exposed areas, and we refer to them as AKs, actinic keratoses. They can have a small risk of squamous cell carcinoma, so a cancer risk for skin cancer. The treatment generally is cryotherapy. A lot of dermatologists we have patients evaluated by to kind of get treated or melt these away. Certainly we'll take some off in the office and send it for pathology review, which will kind of confirm our suspicions. And it's always important to, when looking at these lesions, we do the A, B, C, D, E. So is it asymmetric? The border's irregular? Is it the size, the diameter? Is it evolving? And what's the color? To evaluate whether or not this is kind of a suspicious lesion that is more of a risk of cancer.
Right. And these are very common. And you're seeing more and more dermatologists they'll bring people in and just, it's not even that they remove them, they destroy them. It's cryotherapy or burning them off so they don't keep being irritated and increase that risk for cancer. All right, let's take a look at this next one. This is kind of an itchy area. It's getting slowly bigger. I've been putting cortisone on it, and the cortisone was making it better initially, but then it started to get worse, and I don't know why that happened. So I started using moisturizer. That didn't work. Sometimes the center looks a little clear. What do you think?
So it's in a flexural area, it looks like, and it certainly has this rounded, well circumscribed kind of almost serpiginous, if you like that word, appearance to the border. And this looks like fungal. This looks like a tinea of some type, tinea corpus, something that is a fungal in nature. A lot of times we see satellite lesions, so you see that round circular area with some central clearing. You have to watch with that description. And then with some satellite punctate small red spots. It gets itchy. Like you say, you put a steroid on it. It calms the itch, but the lesion persists. And so we typically use an antifungal either cream or powder, and in severe cases you have to use an oral medication.
Right. These things, they take a while. It can take a couple of weeks of treatment to cool them off. And some people are just at higher risk to get these. Some people, certain type of skin fungal infections they'll get almost seasonally. And it's tempting to say, oh, just give me a pill quick. I want to take a pill. But the pills really aren't the answer. To put a systemic antifungal through your system, that has some liver toxicity and it's not really worth it. Often just the topical things are the key.
Yeah, and I think it's good hygiene and then controlling the underlying condition. So sometimes we'll see that, like you said, if your diabetes is out of control and your sugars are running high, we'll sometimes see a worsening of these fungal infections.
Oh, that's true. Well, that was a good point. Let's wrap up our second segment of It's Your Health. We'll be back after these brief messages to start with another riveting set of headlines. Welcome back to the third and final segment of It's Your Health. Your leader in healthcare news. So let's get back to the headlines. These are the last three you're going to get, and you're going to have to tune in for the next one to get new headlines. You're going to have to chew on these for weeks on end.
They're good though.
But you should watch them because there's pieces in each one that you're going to say, I missed that, I missed that. Easter eggs, I missed that. All right, screen-based media is associated with structural differences in the brains of young children.
This is something we see and we talk about routinely, and it is extremely common in this day and age. And you'll see as well, Phip, with our own families as well as in the office when we have patients who bring in their children. First thing they do, give the phone to the child to allow them to at least kind of focus on themselves and interacting. And we see with more use of kind of cell phones, tablets, TV, that children are having kind of a difference in their brain pathways that lower their literacy in speech as well, just in language as well, and then also their impulse control. And you can sometimes see this, and I notice it with some of my children. If they're on that phone or tablet a little too long and you try to take that away, oh man, it does not end well. And your phrase, all happiness ends in sadness, certainly is seen there. And I think this article gives recommendations on screen time. I think the general theme, less is more.
Right. I think it, to be self-aware, I think it has to do with us as well. I walked out into this waiting room and there was kids just running around, carrying on, screaming. And the one kid kept coming up to his mom. Mom, can I have the cell phone? Mom, can I have the cell phone? Mom, can I have the cell phone? She probably said it he said it a half a dozen times. And what did she do? She just sat there and stared at her cell phone. Says no, about 3 times. Well, what's the problem there? Is this the problem, kid asking for the cell phone, or the mom that won't put the cell phone down? I think they're both the problem,
sure.
And that's really where it is. It's a big problem, and I think it's going to be very interesting as we see these kids growing up, not being able to kind of soothe themselves, not being able to play by themselves. You've said that before. They constantly need to be entertained. They need to have something entertain them. They can't figure it out on their own. And not to be all back in my day, but back in my day, we had to figure that out on our own. And when we would get bored of something, we would move on. They don't get bored of that. Like that never ends, and it's very troubling. I think it's something that we really need to address for our youth. But let's move on. Entresto in heart failure with preserved ejection fraction. There's a recent study in the New England Journal of Medicine addressing the use of Entresto specifically in diastolic heart failure as opposed to what is more common, systolic heart failure.
Sure. So the diastolic heart failure is where there's a filling problem, not necessarily a squeeze problem like with systolic heart failure. And so Entresto for systolic heart failure, it's been shown to be excellent, reduces hospitalization, reduces mortality, kind of has all these great benefits that we've talked about on prior episodes of It's Your Health.
Yeah, you guys know this, of course.
Yes.
I know that. You're aware.
But with diastolic heart failure, it has not shown to have those benefits. An EF of 45% or above, the way your heart squeezes. Entresto, at least in this, did not show as great of a benefit as you would hope for.
Right, and I think it goes to the two different methods.
Yeah.
And I think you explained it really very well, very simply. The systolic is the ability to pump, the diastolic is the ability to fill. And they're two very different problems. And so to have a medication that would hopefully help both would have been great, but it just doesn't work out that way. There's other things we can do. Moving on to our last headline, and this is kind of a mouthful, but we'll just get the headline out. Genotype-Guided Strategy for Oral P2Y Inhibitors in Primary Percutaneous Coronary Intervention. So let's just break that apart for a moment.
Rolls off the tongue.
Yeah, it rolls off the tongue. Basically, what is the role, and you're seeing more and more of this, when patients come in with a report from their insurance or a different provider, a neurologist, they says, oh, my pill says, this report says my genetics, this pill won't work for, and you need to change this medication to maybe something else. And sometimes you've had a patient you tried a medication on and it just didn't work. Like, this should work for them, but it's not. Why is that?
Yeah, so we get into genetic testing, becoming more commonly noted within healthcare. It's thought that healthcare may move to actually putting your genetic profile for how medications are metabolized specifically to you in the electronic medical record. So when you send in a prescription, it'll automatically flag the prescriber, hey, this medication may not work because of this patient's genetic profile. So medications, sometimes we call them prodrugs. That means they're not active before it gets metabolized. So what does the metabolizing? Is the liver, of course. So a lot of things are metabolized by the liver. Some drugs are metabolized in different ways. And so it's not active until it's metabolized. And some people are not good at metabolizing, so they don't get the active medication. So say you have a history of a stroke. You're on this Plavix or clopidogrel, and you're not metabolizing it well, you're at risk for maybe having a further stroke because you're not fully anticoagulated on this antiplatelet therapy. So the thought is, do we test everyone based on their metabolizing ability? And it's thought that maybe we should, maybe we shouldn't. There's not really a strong guideline to force it. I think a driver of this is cost, is how rapid are these tests to come back. Some are point of care, so you get them within 30 minutes. Some may take a week or so. And so it comes down to, will insurance cover that? And then additionally, outside of the antiplatelet realm is, like you said, the neurologist with some of these medications or psychiatrists with antidepressants. Also, with other medications, pain medications as well is a big one. Some people don't respond to, say, an oxycodone or morphine. That's based on their ability to metabolize it and the reason the pain is there as well. But it's not that if we kind of specialize this medicine, specialized individualized medicine, that we could create greater kind of personalized medicine and more efficient.
Right. It just shows you the primordial soup we have of these medications and our genetics and our liver enzymes, and then you throw on top of it, well, this particular medication is inhibiting one of the enzymes that's supposed to help metabolize this one to get ready. Then it really starts to get out of hand. Or something you decided to have for breakfast, like a grapefruit decides to throw off the way your medications work, or some licorice you have at night. It's really amazing, all these different interactions, and we're starting to understand them more and more. So I think we're going to see more and more of that. To what end, though? It is costly testing. It is genetic testing. Well, that about wraps up the last segment of It's Your Health. That was the fastest hour and a half I've ever gone through. So it was really a pleasure. Happy holidays to everybody.
Happy holidays, yes. Tis the season. That's right.
Tis the season. And again, don't slip and fall. We said that before. We'll say it again.
The first segment, yep. Don't fall.
Don't fall. Just don't fall. It's just that easy. Alrighty. Happy holidays to everybody out there in television land, and we will see you all on the next It's Your Health.